My name is Ling Tao. I'm from Xijing Hospital in 4th Military Medical University in China. And our hospital located in Xi'an and in northwest of China. And today, the topic of my late-breaking trial is we call CAGEFREE II trial. And we compare stepwise de-escalation DAPT group compared with standard DAPT group in ACS patients that can be treated with DCB. Currently, there are lacking any randomized trials for this tailored antiplatelet therapy for patients treated with DCB. So in many clinical trials that compares DES with DCB or POBA with DCB, and the trialist recommended DAPT duration ranging from 1 month to 12 months. And because these very notable differences still caused confuse because we do not have any evidence for DCP treatment. So because of the absence of scaffold, mechanic scaffold, and the polymer within the vessels after DCB treatment, and theoretically, the patients treated with DCB can be treated with a less intensive DAPT regimen, but we still need trials to prove the concept. So that's why this trial is the first piece of evidence, and that a randomized trial to show whether less intense antiplatelet therapy may be used for patients treated with DCB. So that's the purpose we design this trial. So the purpose of this trial, I think theoretically, the DCB, because they're absent of mechanic scaffold and the polymer inside the vessels. So theoretically, the patients treated with DCB may need less intensive antiplatelet therapy compared with DS. And in this trial, we have a very specific design and for the experiment arm. And we use 1 month of DAPT with aspirin plus Ticagrelor, followed by 5 months of Ticagrelor Monotherapy, and then 6 months of aspirin, which is different from any other trial that Investigator the DAPT for ACS population in DS. And because there are some trials that try to stop P2Y12 inhibitors at 6 months for DES population in ACS patients, but they're unsuccessful. And so currently they focus on stop aspirin after 3 months or 1 month, but keep P2Y12 inhibitors until 12 months. So our strategy is different from other strategies from DS. So the design, we think in this, the drug-coated balloons have been widely used for viable options in in-stent restenosis and also in small vessels. And currently, they're greatly being used for bifurcation or non-diffuse lesions, as well as high bleeding risk and ACS patients. But we now, I think the interventional cardiologists can start to make many progress on DCB use in clinical setting, but still there's no single randomized trials to show the evidence for how to use antiplatelet therapy after DCB treatment. So the design for this study, the purpose is to provide the first evidence for the patients treated with DCB. But we cannot combine CCS with ACS because the CCS population have the complete different risk profile compared with ACS. And so that's why we do not want to include CCS and ACS in the single antiplatelet the study. But we enroll the patients, not the all ACS population. We include patients with a STEMI, non-STEMI, and UA that's suitable for DCB. So that means it's still different from ACS population, or the population for ACS treated with DES. In our population, and we enroll the patients, just as I said, they have ACS but suitable for DCB. So within our baseline characteristics, we have higher incidence of the patients that with previous PCI, because the doctors think ISR with ACS suitable for DCB. We also have relatively high bleeding risk patients. So this population is still different from the all-comers ACS population. So we combine ACS patients with the treatment, the antiplatelet, and also the device together. And so these patients, we think, is still the ACS patients that are suitable for DCB. And so we have 40% of acute MI and in the study population, and 60% of UA. That might be different from the all ACS population. So these are the inclusion criteria. So that's we screening all ACS population that are treated with DCB, but we exclude the patients with hybrid use of DS plus DCB. We only include DCB-only patients. And in all these DCB-only patients account for 50% of all DCB population. And the DCB-only patients, we have 25% of these patients do not meet the inclusion criteria. So for totally ACS patients that are suitable for DCB and eligible for our study, still account for a large scale of population. And so in this study, and we do not have any restrictions, and for lesion type, de novo and ISR can all be included. We do not have any restrictions for vessel size, and no restrictions for DCB of any brand of DCB. If it's a paclitaxel DCB, can be included. And also, we do the study at 41 sites in China, and we totally include 1,948 patients, and within 14 months. And so it become a very widespread use of DCB in China. But all these patients that treatment with DCB have at least more than two reasons that use DCB. For example, some patient with ACS, but they're suitable for DCB because of their ISR lesions, or 55% of small vessel disease, and 45% of bifurcation lesions, and about 20% of high bleeding risk. So we are not emphasize this is the ACS population. This is a population that really have the reasons use DCB. The primary endpoint was NACE that include all-cause deaths, stroke, MI, revascularization, and type 3 and type 5 bleeding events. So we estimate the primary event rate were 8%, and because we do not have many data for DCB, so we consider that the ischemic events may be comparable or higher than the patients treated with DS, but the bleeding events may be comparable with DS because they have same antiplatelet therapy. So we estimate 8%, and we the non-inferiority margin was 3.2%. That's 40% of event rates. So we also set one side alpha of 5% and 80% of power and attrition rate of 5%. So that's how we calculate the numbers of patients enrolled. So totally we enrolled 948 patients. The major findings, we found that the cumulative NACE at 1 year in de-escalation group was 9%, and a standard 12-month DAPT group was 8.7%. So the difference is 0.31%. So the upper boundary of 95% confidence intervals was 2.43%. So we meet the criteria, the non-inferior margin of 3.2%. So that means first the finding that we show the evidence that for the ACS patients that can be treated with DCB, they have comparable NACE if they with de-escalation DAPT strategy. So that means we meet our criteria, and for these patients, I think the clinical, for real world practice, we may think about a shortened DAPT, and we can our de-escalation strategy and could be considered in clinical practice. And also the other findings, we also analyze the clinical relevant ischemic and also bleeding risks. So in a win ratio method, so we pre-specified a hierarchical order of clinical importance with death, stroke, MI, and revascularization, a BAC3 revascularization, and a BAC2. So if we specified in a clinical important order, and we make comparisons, use win ratio, that means we compare each patient in de-escalation group with each patient in standard DAPT group. So we have to compare 975 multiple 973 pairs. And so after this comparison, we use a win ratio method, we found that in de-escalation group, we have 14.4% of wins. And in the standard DAPT group, have 10.1% of wins and other tires. So, but this clinical relevant ischemic and bleeding events, from this result, we can show significantly lower in de-escalation group. So that means overall benefit for this de-escalation group is still positive. And mainly due to so the composite of bleeding risk, like a BAC2, 3, 5, or BAC3, 5, and some components, and except for type 5 bleeding, all the other components or significantly decreased in this de-escalation group. I think the hierarchical comparison of these bleeding and ischemic events may be underpowered because the sample calculation, we did not calculate sample population for win ratio because it's difficult. But this positive result still can be considered hypothesis generating. So for overall this study, we think the importance of this study, and it provides the first piece of evidence of how to use DAPT and after treatment with DCB. And second, we think that the strategy and we designed the stepwise de-escalation strategy and shows non-inferiority for NACE compared with standard DAPT group. And also, if we consider clinical relevant ischemic and bleeding events, we found that overall benefits may be still favor de-escalation group. So that's the importance of these main findings. So also we think still limitations. Of course, we have some limitations, so we still need to think about. And first, we have a limitation of open label design. So, but we use clinical endpoints for this study. And also we develop APP and we contact the patients to improve the adherence for medication. So the overall adherence for per protocol, it's over 85%. If some non-compliance because of they cannot tolerate Ticagrelor because of this year, they change to clopidogrel. So if we consider both Ticagrelor and clopidogrel, all consider it's compliant. So our compliance rate will increase to 95%. So I think even it's open label and the quality and the compliance rate is still high. And also if the CEC to adjudicate these events and all core lab and also statisticians were blinded to this analysis. So I think the open label can be addressed. And some other limitation because we still think that although we enrolled STEMI, non-STEMI, and UA, but it's still not the population of ACS population. I emphasize many times it's a DCB antiplatelet therapy for DCB. So it's not all ACS population. It's ACS patients that can be suitable for DCB treatment. So I think this is also the limitation because the percentage of acute MI in our study only 40%. So might be if a trial and in the future to explore a solely acute MI probably also needed because the percentage of STEMI in our study only 16% because a limited number of STEMI. So I think acute MI maybe need another further investigation. So for this study, it's also, I think it's a limitation. But we still think it's very important for the interventional cardiologists in real-world setting because currently they're confused with DCB. They start from 1 month to 12 months. They use different antiplatelet regimen at different hospitals. I think we need a trial to show the overall benefit of de-escalation of DAPT and to prove the concept that DCB may need less intensive antiplatelet therapy. I think it's important. Investigators so try to explore the best DAPT regimen for ACS patients, because these patients' population have higher bleeding and a higher thrombosis risk. So they try many regimens. One is stop aspirin. So maybe after 1 month or 3 months DAPT, stop aspirin and keep a single P2Y12 inhibitors. So for this kind of design, ensures comparable ischemic events, but decreased bleeding events. So this now be used in ACS patients treated with DS. But the problem is still 12 months of intensive antiplatelet, even with single P2Y12 monotherapy. And also there are some other trials to stop DAPT at 6 months. So, and after that, and just use aspirin monotherapy for high bleeding risk patients. So all these efforts all being tested in DS in patients treated with DS, but it still not can be expanded to DCB. So DCB is still different. So our trial is to prove that if with shortened DAPT and also with de-escalation of P2Y12 inhibitor to aspirin. So this de-escalation, I think, is also important to decrease the incidence of bleeding events. So and also I think it's important to use to base on Ticagrelor monotherapy, but not Cardiology monotherapy. I think it's important to emphasis of this, because for the patient that cannot tolerate Ticagrelor and then change to Cardiology and cause the non-adherence rate. For this patient with Cardiology monotherapy, they may increase ischemic events. So our de-escalation, this strategy, I think is still based on Ticagrelor. So we want, so the clinical setting, they focus on 1 month of DAPT. After that, stick to Ticagrelor-based monotherapy. So I think it can decrease ischemic events compared with Cardiology monotherapy. So I think in these clinical settings, now in our department and in Chinese, many Chinese centers, they start to use our de-escalation strategy for ACS patients that treated with DCB. And so like I said, the overall benefit is still, we can see that it's obvious. DCB now has a viable option for patients with in-stage restenosis and also small vessel diseases, but it's still in controversy that used for other situation for include ACS. So now we use this trial we use for ACS patients with some reasons. For example, with bifurcation, with small vessel disease, with ISR, with high bleeding risk. But if exclusively use DCB for ACS patients, might not be I think it's still not cannot be expanded use because lack of evidence. So I think we have more things to do. And first, if we want to expand this DCB use in ACS patients, we may need more trials to compare DCB and the DS in these patients. And so this is the importance for incidence of how to use DCB. So this trial is not designed to encourage the use for DCB in ACS population. This is not the purpose. So I don't want to encourage the use for DCB in ACS patients. And the second is, so as I said, when we use this DCB in this population and relatively low percentage of STEMI, and because some STEMI patients with thrombus, and it's not suitable for DCB. So in current study, and we have 40% of acute MI and 60% of UA, and they may think this not represent for all ACS population. So I think the DAPT trial for DCB in acute MI patients might be need further investigated. So there are two things need to be further investigated: indications and also expanded use for acute MI.